Hello, my name is Jun Chul Park. I'm a professor at Yonsei University, College of Medicine in Seoul, Korea. It is my great pleasure to introduce you my recent published article in Endoscopy. The title is Endoscopic Vacuum Therapy for the Management of Upper GI Leaks and Perforations, a multicenter retrospective study of factors associated with treatment failures. Upper GI leaks and perforations lead to a serious condition associated with high morbidity and mortality. The optimal method for managing upper GI leaks and perforations remains controversial. Although surgery is a treatment option, it is associated with a mortality rate of 12 to nearly 50%, depending on the organ. Therefore, non-invasive endoscopic treatment has recently been published over surgery. Recently, endoscopic vacuum therapy has shown excellent efficacy in managing upper GI leaks and perforations. Vacuum therapy uses continuous negative pressure to drain the infected fluid and accelerate wound healing. A recent systemic review showed that the mortality rate with vacuum therapy in patients with anastomotic leakage after asphyxectomy was the lowest compared to those of conservative, stent, or surgical treatment. However, the clinical success rate of endoscopic vacuum therapy varied too widely, ranging from 66 to 100%. In addition, there are not many reports of a success rate for upper GI organs other than the esophagus. Although the risk factors associated with successful SEMS insertion have been reported, but only few reports have focused on the factors associated with successful endoscopic vacuum therapy treatment. And even in these studies, the number of enrolled patients for analysis was very small. Therefore, in the current study, we investigate the risk factors for failed endoscopic vacuum therapy in a large number of patients than that included in the previous study. In particular, we analyzed patients from institutions that treated most patients with esophageal and gastric cancer in South Korea. And unlike the previous studies that mainly focused on the esophagus, our study included not only the esophagus, but also relative more cases of gastric leaks and perforation after surgery, especially gastric cancers. 4 referral hospitals participated in this retrospective multicenter study. 119 patients who underwent vacuum therapy for upper GI perforation or leaks were included. The clinical success rate was 70.6%, and 75% of patients underwent vacuum therapy as a primary therapy, and the rest of patients as rescue therapy. On multivariate analysis, neoadjuvant treatment and the intraluminal method were significant independent risk factor for vacuum therapy failure. The sponge was changed every 7 days on average, according to lesion status. The longest interval was 21 days, and the interval of vacuum therapy treatment did not affect the failure. I think the timing of a sponge change should be considered depend on the lesion status. Endoscopic vacuum therapy is a relatively safe procedure. No significant bleeding was observed in this study. The only adverse event were dislocation of sponge and aspiration pneumonia. If the dislocation sponge could not be removed easily, the sponge could be withdrawn a few hours later, stopping the negative pressure. The overall survival rate of the vacuum therapy success group was significantly higher than that of the failure group. And 7 patients died due to leakage-related adverse events, but no death was caused by the vacuum therapy itself. This study has several limitations. First, clinical heterogeneity was inevitable, and we could not evaluate other factors such as mucosal ischemia and exact value of negative pressure that affected vacuum therapy failure. Based on current and previous study, I think endoscopic vacuum therapy is a promising treatment method for upper GI leaks and perforation. However, we have to keep in mind that previous neoadjuvant treatment and the method of endoscopic vacuum therapy like intraluminal method could affect the poor prognosis of vacuum therapy before the procedure. Thank you for your attention.